Assalamu alaikum. I am Dr. Ayesha. Today we will be talking about trachea and esophagus. We'll talk about their anatomical features, their course in the mediastinum, and their important clinical relations. Let's begin with the anatomical features of trachea. The trachea, which is also known as the windpipe, is a wide tube lying more or less in the midline. As you can see in this image, this is the trachea, the windpipe. This trachea, it lies in the lower part of the neck and in the superior mediastinum. Its upper end, as you can see here, is continuous with the lower end of the larynx. The trachea in the neck is covered by isthmus of the thyroid gland and acts as a shield for trachea. At its lower end, the trachea divides into two main principal bronchi, which are known as right and left principal bronchi. The origin of the trachea, or you can say the trachea, begins at the level of cricoid cartilage opposite the sixth cervical vertebra. Whereas it ends at the level of T4 thoracic vertebra opposite the sternal angle. That is why the trachea is a content of superior mediastinum. It does not passes down into the posterior mediastinum, as it ends before reaching the posterior mediastinum at the level of T4 thoracic vertebra. So the extent of trachea is from sixth cervical vertebra up to the fourth thoracic vertebra, where it ends by dividing into two main principal bronchi. The trachea is 10 to 15 centimeter in length. Upper end of the trachea lies at the lower border of cricoid cartilage, as you can see here. In the cadaver, its bifurcated lower end lies at the lower border of T4 thoracic vertebra, corresponding in front of the sternal angle. However, in living subjects, in the erect posture, the bifurcation lies at the lower border of sixth thoracic vertebra. It descends still further during inspiration. Over most of its length, the trachea lies in the median plane, as you can see here, but near the lower end of the trachea, it deviates slightly to the right. As it runs downwards, the trachea passes slightly backwards, following the curvature of the spine. Now let's talk about the tracheobronchial tree. As I have already told you, the trachea divides at the level of lower border of fourth thoracic vertebra. This is the trachea, which is dividing at the lower border of fourth thoracic vertebra into two primary principal bronchi, one for each lung. This is the right principal bronchus. This is the left principal bronchus. The right principal bronchus, as you can see in this image, it is shorter, wider and more in line with the trachea than the left principal bronchus. It is about 2.5 centimeter long. Inhaled particles or foreign bodies therefore tend to pass more frequently to the right lung, with the result that infections are more common on the right side than on the left. Coming to the left main bronchus, it is about 5 centimeter long. It is longer, narrower and more oblique than the right bronchus. Right bronchus makes an angle of 25 degrees with the tracheal bifurcation, while the left bronchus makes an angle of 45 degrees with the trachea. If we say this is the midline or median plane of the trachea, you can see right bronchus is making an angle of 25 with this bifurcation, while the left bronchus is making an angle of 45 degrees with the bifurcation of trachea. Each principal bronchus enters the lung through the hilum, as you already know this, and divides further into secondary lobar bronchi, one for each lobe of the lungs. In this way, we have 3 lobar bronchi on the right side, as we have 3 lobes in the right lung, and only 2 lobar bronchi on the left side, as we have 2 lobes in the left lung. Each lobar bronchus then further divides into the tertiary or segmental bronchi. These are the segmental bronchi, as you can see in this image. These segmental bronchi, they supply the bronchopulmonary segments, which are 10 on the right side and 10 on the left side. These segmental bronchi, as you can see here, they divide repeatedly to form very small branches called terminal bronchioles. These are the terminal bronchioles. Still smaller branches are called the respiratory bronchiole. This is the respiratory bronchiole. Each respiratory bronchiole aerates a small part of lung known as the pulmonary unit. These respiratory bronchioles, they ends in microscopic passages which are termed as alveolar sacs, atria, or pulmonary alveoli. Gaseous re-exchange takes place basically in these alveoli. I repeat, this is the trachea, which divides at the lower border of 4th thoracic vertebra into 2 main principal bronchi, one for each lung. These principal bronchi further divides into the lobar bronchi, which supply each lobe of the lung. These lobar bronchi further divides into segmental bronchi. These are the segmental bronchi, which are 10 in number. They supply the 10 bronchopulmonary segments of the lungs. These segmental bronchi, they further divides into the smaller units, which are termed as the terminal bronchioles and the respiratory bronchiole. Respiratory bronchiole further divides to form the smaller microscopic units, which are termed as the alveoli, where the gaseous exchange takes place. That's all about the tracheobronchial tree. Now let's talk about the relations of the trachea, relations of the thoracic part of trachea. This image is showing the anterior relations of thoracic part of trachea. Anteriorly, the trachea is related to the manubrium sterni, sternothyroid muscles, remains of the thymus, left brachiocephalic and inferior thyroid veins, as you can see here, arch of aorta, brachiocephalic and left common carotid arteries, deep cardiac plexus, and some lymph nodes. This image is showing the posterior and lateral relations of the trachea. As we all know, that posteriorly trachea is related to the esophagus and vertebral column. On each side, in the neck, it is related to the common carotid arteries, right and left lobes of the thyroid gland, inferior thyroid arteries, the recurrent nerves. These were the relations of the cervical part of trachea. The thoracic part of trachea is related on the right side to the right lung and pleura, right vagus nerve and azygous vein, while on the left side it is related to the arch of aorta and the recurrent laryngeal nerve of the left side. The trachea, as you can see in this image, it has a fibroelastic wall supported by a cartilaginous skeleton formed by C-shaped rings. These rings are about 16 to 20 in number and make the tube convex anterolaterally. Posteriorly, there is a gap which is closed by a fibroelastic membrane and contains transversely arranged smooth muscle known as trachealis. That's all about the relations and structure of trachea. Now let's talk about the blood supply of the trachea. Upper part of the trachea is supplied by the inferior thyroid artery, while the lower part is supplied by branches of the bronchial artery. Talking about the venous drainage, it is drained into the inferior thyroid venous plexus, while the lower part is drained into the left brachiocephalic vein. Talking about the nerve supply of trachea, the parasympathetic nerve supply to the trachea is through right and left vagus nerves and the recurrent laryngeal nerves. This parasympathetic supply is sensory and secretomotor to the mucous membrane, and it is motor to the trachealis muscle. Sympathetic supply to the trachea is from the middle cervical ganglion, which reaches trachea along the inferior thyroid arteries. Lymphatics from the trachea are drained to the pretracheal and paratracheal nodes. That's all about the trachea. Now let's begin with the anatomical features of esophagus. Esophagus is a narrow muscular tube forming the food passage between the pharynx and the stomach. This part, this whole orange part you can see in this image is the esophagus. It extends from the lower part of the neck to the upper part of the abdomen. The esophagus is about 25 cm long. The tube is flattened anteroposteriorly and the lumen is kept collapsed. It dilates only during the passage of food bolus. The pharyngo-esophageal junction is the narrowest part of the alimentary canal except for the vermiform appendix. The esophagus begins in the neck at the lower border of cricoid cartilage opposite the sixth cervical vertebra, as you can see in this image. At this point, it is continuous with the lower end of the pharynx. It then descends in front of the vertebral column through the superior and posterior parts of the mediastinum. Unlike trachea, which is a content of superior mediastinum only, it does not passes through the posterior mediastinum, while the esophagus, it begins at the lower part of the neck, passes through the superior mediastinum, and it descends in the posterior mediastinum. It pierces the diaphragm at the level of T10th thoracic vertebra. This line, this is the diaphragm. As you can see here, it pierces the diaphragm to become continuous with the stomach, cardiac end of the stomach. It ends by opening into the stomach at its cardiac end at the level of 11th thoracic vertebra. I repeat, the esophagus starts at the lower border of cricoid cartilage. It passes through superior and posterior mediastinums. It pierces the diaphragm at the level of T10th thoracic vertebra. This opening is known as esophageal hiatus of the diaphragm. It then ends in the cardiac end of the stomach at the level of 11th thoracic vertebra. Now, talking about the curvatures of the esophagus. In general, the esophagus is vertical, as you can see here, but it shows slight curvatures in the following directions. There are two side-to-side curvatures, both towards the left. One is at the root of the neck and the other near the lower end. It also has anteroposterior curvatures that correspond to the curvatures of cervicothoracic spine. Now let's talk about the esophageal constrictions. Normally, esophagus shows 4 constrictions levels. This line is indicating the length in centimeters from the incisor teeth. This is the level of upper central incisors. This is showing the distance from the incisor teeth. At its beginning, the first constriction is at its beginning 15 centimeter from the incisor teeth. This is the cricoid cartilage. As we all know that esophagus begins at the lower border of this cricoid cartilage. This first constriction, it lies at the distance of 15 centimeter from the incisor teeth. As you can see here, 15 centimeter from the incisor teeth. This constriction is the level where it is crossed by the cricopharyngeus muscle. The second constriction is at the distance of 22.5 centimeter from the incisor teeth, at about this level, where it is crossed by the aortic arch. The third constriction is about the distance of 27.5 centimeter from the incisor teeth, at this level, where it is crossed by the left bronchus. The fourth constriction is at the point where it pierces the diaphragm, which is 37.5 centimeter from the incisor teeth, at about this level. The distance from the incisor teeth is very important in passing the instruments like endoscope into the esophagus. Now let's discuss what is the clinical importance of these esophageal constrictions. Why do we need to know about these esophageal constrictions? The first clinical importance of these constrictions are, these are the sites where swallowed foreign bodies may stuck in the esophagus. The second point is, these are the sites where strictures develop after ingestion of caustic substances. The third point is, these are the sites, or these are the common sites for the carcinoma of esophagus. The carcinoma of esophagus most commonly develop at these sites. The fourth and the most important point is, these are the sites via which it might be difficult to pass the esophagoscope or the gastric tube. So we must know the levels of these esophageal constrictions before these procedures. Now let's talk about the relations of thoracic part of esophagus. This red muscular structure, as you can see here, this is the esophagus, this blue one is the trachea, and this is the vertebral column. This is the side view of the mediastinum, showing relations of esophagus with the other contents of mediastinum. Anteriorly, the esophagus is related to the trachea, right pulmonary artery, left bronchus, pericardium with left atrium, and the diaphragm. This is the diaphragm. Posteriorly, this esophagus is related to the vertebral column throughout its length, as you can see here. Right posterior intercostal arteries, thoracic duct, azygous vein with the terminal parts of the hemiazygous veins, thoracic aorta, right pleural recess, and the diaphragm. To the right side, esophagus is related to the right lung and pleura, azygous vein, and the right vagus. On the left side, it is related to the aortic arch, this one, left subclavian artery, thoracic duct, left lung and pleura, left recurrent laryngeal nerve, descending thoracic aorta, and left lung and mediastinal pleura in the posterior mediastinum. Now let's talk about the arterial supply of the esophagus. For convenience, we have divided the esophagus into three parts: the cervical part, thoracic part, and the abdominal part. Talking about the blood supply of cervical part, it is supplied by the inferior thyroid artery. These are the esophageal branches from the inferior thyroid artery. The thoracic part of the esophagus is supplied by esophageal branches of the aorta. These are the esophageal branches of aorta, as you can see here. The abdominal part is supplied by esophageal branches of the left gastric artery. This is the left gastric artery, and these are the esophageal branches of left gastric artery. Talking about the venous drainage, blood from the upper part of esophagus drains into the brachiocephalic veins. From the middle part, it goes to the azygous venous system, and from the lower end, it goes to the left gastric vein and azygous veins. The lower end of the esophagus is one of the sites of portosystemic anastomosis. Talking about the nerve supply of esophagus, sympathetic supply to the upper half of the esophagus comes from middle cervical ganglion and run with inferior thyroid arteries. For lower half, the fibers come directly from upper 4 thoracic ganglia to form esophageal plexus before supplying the esophagus. Sympathetic nerves to the esophagus are vasomotor. Parasympathetic supply to the upper half of esophagus is by recurrent laryngeal nerves, while parasympathetic supply to the lower part or lower half is through esophageal plexus formed mainly by two vagus nerves. Parasympathetic nerves are sensory, motor, and secretomotor to the esophagus. Talking about lymphatic drainage of the esophagus, the cervical part of esophagus drains to the deep cervical lymph nodes, the thoracic part to the posterior mediastinal lymph nodes, while the abdominal part drains to the left gastric nodes. That's all about the anatomical features, relations, and blood supply of the esophagus. So far, we are done with the anatomical features and relations of esophagus. Now, let's talk about the important clinical facts regarding esophagus. The first one is the esophageal varices. What are esophageal varices? In portal hypertension, the communications between portal and systemic veins draining the lower end of esophagus dilate. As you can see here, these dilatations are called as esophageal varices. Rupture of these varices can cause serious hematemesis or vomiting of blood. The esophageal varices can be visualized radiographically by barium swallow. In barium swallow, they produce worm-like shadows. These are the esophageal varices. These are basically the dilatations of portal and systemic veins which are draining the lower end of esophagus. The normal indentations or constrictions on the esophagus should be kept in mind during esophagoscopy. These are the normal constrictions, as I have already told you, which must be kept in mind during the esophagoscopy or gastroscopy. The second important clinical point about esophagus is during barium swallow, we can diagnose the left atrial enlargement as in cases of mitral stenosis. The enlarged atrium causes a shallow depression on the front of the esophagus, which can be visualized by barium swallow. Barium swallow also helps in diagnosis of esophageal strictures, carcinoma and achalasia cardia. What is achalasia cardia? As we all know that the lower end of esophagus is normally kept closed. In cases of neuromuscular incoordination, the lower end of esophagus, it fails to dilate with the arrival of food, which therefore accumulates in the esophagus. As you can see in this image, the lower esophageal sphincter fails to relax on arrival of food, due to which there is esophageal dilatation due to backup of food. This condition of neuromuscular incoordination is characterized by inability of esophagus to dilate. It is known as achalasia cardia. It may be due to congenital absence of nerve cells in the wall of esophagus. The last important fact about trachea and esophagus is there might be improper separation of trachea from the esophagus during development, which may lead to the formation of tracheoesophageal fistula. As you can see in this image, this is lower segment of esophagus which is connected to the trachea, and there is esophageal atresia of the upper segment of esophagus. That's all about the clinicals of esophagus.